Sir, and sir is always with our department, especially with me. दोनों एक सोल देना प्रोफेसर.
हमारा वाला भी हमारे साथ चिपका.
Sir is very supportive of our specialty, our discipline, especially me. Most of the time guide me, and most of the time मतलब डांटते भी रहते हैं, मतलब जब भी मौका मिलता है छोड़ते नहीं हैं. हाँ तो सर.
डांट में तो प्यार है.
सर प्लीज.
थैंक यू.
और आप थोड़ा हमारे प्रेसिडेंट साहब को फेलिसिटेट कर दीजिए.
जरूर. माइक कहाँ है? और साइन कर देता था. बहुत सारा पेशेंट में हम देखे तो हमको समझ में नहीं आया कि तुम ये क्या लिख देते हो. वो बोला कि इसका फुल फॉर्म, आजकल तो बहुत फुल फॉर्म आ गया ना बच्चों. तो बोला कि सर या तो आप समझते हैं या तो भगवान जानता है. गॉड नोज का शॉर्ट. आइए भाई आइए.
Surgical aspect of spinal cord injury rehabilitation from surgeon perspective.
Thank you. आप बताओ. आइए.
Spinal cord injury, and from pediatrics decision making is a intervention approach, type of implants, expected complication that was allotted to me by organizing team. And first I have to understand this topic, and I had taken so much time to understand what is the topic. And then I remember the things, what is expected from me. I tried my best to inculcate what is the basic things, and I hope this will be very useful for the residents. And Dr. Paul sir and the previous speaker, Dr. Sanjeev Ghosh, had already given the brief of the anatomy and the hugely entertaining and knowledgeable aspect of that reflex mechanism, spinal shock and recovery mode, and the failure mode. Now, when we see the patient, the spinal cord injury per se is not just an injury of the spinal cord, but what it is the injury to the vertebral column also, which harbors the spinal cord and protects it. So, it is the injury of both the vertebral column and the spinal cord. It is not only the spinal cord that is injured. You can see it here, just to give a glimpse. It is the protection layer of vertebral column, vertebral body, vertebral body. This is pedicle, this is lamina, this is spinal process, and this is the spinal canal. It is the spinal cord is there. So first, any injury has to damage the outer protecting layer and go inside. So whatever we are discussing in this topic is just a traumatic thing. A spinal cord injury can be the metabolic, it can be neurogenic, it can be infective. I am not going upon those aspects. It is mainly based on the traumatic, and other parts can come across later. Now, in day-to-day practice, what we see, what we observe, is scenario like this, and it is one of the most common cause of injury in our day-to-day observations. Few people lying on the road after the motor vehicle accident. This is a adult patient, this is child patient. Followed by it, you can see sometimes the fall from height, the second most common cause. And it is very difficult to say the patient is having only the spinal cord injury, because incidence wise, it is the first, the limb injury first, followed by abdomen, followed by chest, followed by head injury, and then the spine injury, and followed by the pelvic injury. So we have to keep the suspicion of a spinal injury, but the motto is to focus upon the primary survey, ABC, the principle of the trauma management, then the secondary survey, and to keep the suspicion of the spinal injury high after all establishing these injuries. So, and the spinal cord, you can see the position of the neck, one of the most vital sectors, and our whole emphasis on starting the spinal cord injury to management of the cervical spine and its stabilization. That will subsequently know the slides. So, when we see a patient, anybody who has undergone the trauma and accident and lying on the roadside, what is our reaction? Now it is time to act. We have read anatomy concept, we have read the physiology concept, we know something about the treatment. But after all, being a doctor, being a physician, being a rehabilitatist, what is the thought? Now, the prime important thing is call for the help. As we call for the teacher self, we call senior self, we call for the interventionist. So you have to call the nearby hospital for the help before starting anything to save yourself, to save the patient. Now, after calling that, what you will do the next is to do the initial assessment of the patient. There is a primary survey to establish the airway, breathing, suppression, whatever the needs you have. And the secondary survey to assess for the spinal injury. There are different methods to assess for the spinal injury. And this is the photo just depicting to put the patient on the spinal board. It is a rigid board, just to put the spine on the plane, because you are very versed with it. Because rehabilitation is very important, and this is one of the basic concepts that starts. We have to follow it. And stabilization of the cervical spine, because we know cervical spine is the center from where respiratory and cardiac center is located, and if any injury happens there, patient will go in the rest and everything is prepared. So you have to stabilize the cervical spine, that is the first step. And this spinal board is just a depiction. You can get in the field anything that can resemble it. Now the second aspect is the helmet. Majority of the time the public people who undergoes road traffic accident wears a public, and this is one of thing that you should know how to take out helmet. That is Harvik's maneuver. One person stabilizes the spine, other persons put the fingers beneath the helmet and bilaterally flexing it and slight maneuvering, keeping in view that occipit and the nose are clear, and it is taken out without moving the cervical spine, which is very important aspect and primary aspect of following the injury. This is just a chart to show that we should know about the sensory pattern of the body, motor, and it is very important to know all these things where C2 level, C3 level, C4 level, T4 level, T10 level, and other sensory areas are there. Sensory evaluation is very difficult because sometimes we can get the patient who are conscious, sometimes we can get the patient who are not conscious. So it is very difficult to assess the sensory examination. We can do, but we should try to go for that because it helps in localizing where the injury can be. The motor aspect. Motor aspect we can also, just like sensory motor, if the patient is not similarly helpful, but if he is unconscious, he can do it. But we can assess, as we commonly assess the patient by glassoma scale, that patient is moving the lips and what are the extent of moving the lips on the pain and automatic spontaneous. This is just a chart to fill up so that we can localize. For example, if we think that patient is having numbness at the level of cervical collar, so we can suspect that patient is having C4 level injury. If the patient is saying that I am having numbness at the C4 level, then we can suspect that patient is having C4 level injury. Patient is having complaint of tightness at the level of umbilicus, we can suspect that patient is having injury corresponding to the D10 level. There are slight mismatch on the vertebral level and spinal cord level that we know there is some discrepancy. If we localize in the level above T6, if it comes near T4, then the spinal cord level will be T2 level. We have to subtract 2 above the T6 and 3 below T6. At the level of umbilicus, if there is numbness, then the spinal cord level will be T7. Now we have gone through the anatomy just to see the picture that spinal cord is lying in this spinal canal. This is the protection layer, vertebral body. This is pedicle, this is lamina, this is spinous process. The basic motto of managing a patient in spinal cord injury is the immediate mechanical stability. We have to stabilize the vertebral column that we have seen how we have put the patient on the spinal board. We have stabilized the cervical spine by putting the cervical collar. And then we go for the neurological stability. It can be achieved by conservative means also, it can be achieved by surgical means also, that we will come across in subsequent slides. And we have to assess for the potential long-term stability in the patient also, by managing the patient. Now, when we do all the examination of the patient, primary assessment, secondary assessment, and patient is shifted to hospital, and then in the nearby hospital, the first thing that come across, should the radiography be done or not? Now, there are only few indications that where X-ray cannot be done. But there is presently, I will say that there is no indication that X-ray should not be done. And we have not only do the X-ray, but we sit on the CT where the facilities are available, because it is one of the things where we can screen the patient for cervical injury, head injury, and all the injuries in very short span of time, within 2 to 3 minutes. So CT is one of the most important investigation in such lesion besides X-ray, because CT scan facility is not available everywhere, but X-ray facilities are available. So being a rheumatologist, being a physician, being a neurosurgeon, we should have at least a fair bit of ideas about the spinal injury while seeing the X-ray. I will just give a glimpse on subsequent slides. Because when we see the X-ray, this is the very basic thing that we come across. And we should know where the interspinal line, this is called contour line. This line is adherent to anterior vertebral body, this is posterior vertebral body, this is drawn across the spinal lateral line, and this is on the tip of the spinal process. If any agent is there, we can suspect that if it is on the anterior, then there is something wrong at the vertebral body level. If it is on this second line, then we can suspect that there is something wrong in the posterior column. If it is at the spinal lateral line, then we can say that it is something wrong in the pediculum and the lamina. And if it is there, we can think of a spinal process. These are very basic things. And this is one of the things that we commonly across in hospital setup, all of us. We can see these contour lines, we can see the vertebral disc space, we can see the fracture line on this X-ray, and that will give a fair bit of idea. And the next speaker will also tell you something about how to see the X-rays in this. Now, this spinal column has been divided into 3 parts by authors: anterior column, mid column, and posterior column. Anterior 2/3, mid 1/3, and posterior column posterior to the posterior longitudinal ligament. That is technical term. But say this is the class. This is the table which show the scoring for. It is for the thoracic lumbar spine, but what I will like to say, this is for the cervical spine also, this is for the thoracic lumbar spine also, and it is almost universal to assess the morphology. Either it is because of the compression. First thing is the morphology. Either it is because of the there is no abnormality on the X-ray. There is compression, there is burst, there is extension, this is rotation. Distal ligamentous complex you can better assess on the MRI and CT scan, and neurological status. It is on the intact, either foot injury or complete spinal cord injury or incomplete spinal cord injury. Anything greater than 4 requires surgery, anything less than 4 requires conservative treatment by either it is zero waste or by Philadelphia cervical color that you have. So we should be very clear, we should remember this. And we should also remember that anything greater than 4 requires surgery and less than that requires conservative management. And that is the basic model. Surgical time in acute traumatic spinal cord injury. In any of the incomplete spinal injury that you have seen in the last talk, that diabetic spine was the defective spinal pathology, you can come across the pictures like bronchic cord, you can get the picture of anterior spinal artery syndrome, you can get the picture of syringomyelic syndrome. So these are incomplete spinal cord injury syndrome, and anything in incomplete spinal injury cord syndrome requires spinal stabilization, vertebral stabilization per se. And the timing of the surgery should be as early as possible so that the further injury to the spinal cord can be avoided. Now coming to the spinal cord segment one by one. First to start with is the neurosurgical junction. It is one of the most important that I have talked earlier, and particularly why it is important, because the spinal center, cardiac center, rehabilitation center are there, and if it is not properly aligned and proper stability is there, then it can, the vertebral body as identified can compress and the patient can die on the spot. So cervical stabilization is very important. Role of magnetic resonance imaging is very important, because majority of the time it is the ligamentous injury that is causing the mobility of the oratoid, C1 spine, C2 spine, and all the things. Other things you can assess, and it gives fair bit of idea of spinal cord changes also, hyperintensity changes, suggesting of spinal cord edema. There are various parameters to assess the spinal stability that you can see here. This is the vision, this is your vision, this is the oratoid process, C1 anterior arch, C1 posterior arch, C2 body, C2 spinal process, and there are different parameters to assess it that we have to go through that. Just to give you a basic idea, when we are open mouth oratoid view gives you the idea of oratoid process. You can see it here, the displacement of lateral mass, that you can get idea about it in peripheral field also. It is not. This is the scan of the CT scan, where different parametric lines are there to see the stability. And anything that about line shows that one has gone outside because of the injury, and that is the secondary post-traumatic. Now, what can be the treatment in such circumstances? It is majority of the time it is conservative, but there is always discussion between traction and hollow-waist application. That is the base. Now, in our scenario, the application of the brace stabilizes the occipital cervical junction or craniovertebral junction better than putting this Philadelphia cervical collar. And if there is no neurological deficit, then patient's bony fracture can heal in 8 to 12 weeks. So traction is not very much required presently. How we apply it, you can see it here. We day-to-day apply the hollow base just on the frontal and occipital aspect. The main pillar is there. It is supported by the rod, which is attached to the breast on the chest. This is the routine case scenario in our ward where we apply the traction, but I personally do not favor this traction other than that non-traumatic injuries, because, and I will like to highlight some, because and always try to put start on the lower bedside around 2 kg and never try to go above 3.5 kg, because that was unnecessary hypertension injury of spinal cord, and I have not a good experience on managing the patient as it could be having bad results subsequently. And while we have to operating the patient, you can see here it is just ongoing development of applying the implants. Earlier this was a treatment pin that was contoured and with the wires it was fixed. Occipital cervical was done. Subsequently it was occipital pin. Now it is done with the pedicle screws in occipital plates. So there are lots of changes now. Isolated single fracture are very less, 1-2%, but they are almost neurological stable. We hardly come across that can cause neurological injury. C2 axis fracture is composed of that C2 body fragments, facet fracture, and foramen transverse also. You can see the rod is there, but not all the fracture requires treatment. But if it is more than type 2C, then the displacement is more than 1 millimeter, and other fracture that Hammond type that goes across the body and pedicle that requires surgical fixation. Generally for rotary screws we use the rotary screws that goes through the lower border to the rotary process. There are lots of indication, contraindication. I am not going upon that, but this is the treatment that we used to follow for the rotary, and it is almost contraindicated for the posterior inclined rotary, and we can use it for the anterior inclined rotary with the fair bit of patients. Now this technique is most commonly used C1 C2 fixation. Everybody knows it through the dorsal aspect to the both of the lateral mass. There is ongoing discussion about the technique because this is performed in India by Professor Goel, LDC, who was ex-head of KM, currently director of PhD. And you can say that it is started by AIIMS. So in Europe this was AIIMS technique, but in India we call it Goel's technique. There is another hangers fracture where the nipples are hanged and this bilateral pedicle fracture is there. Majority of the time patients are stable in one type 2, but in type 3 when the hang is more than 30 degrees and displacement is more than 3 mm, we require surgical fixation. Then we have to identify the axis. Depending upon the extent of trauma, we require to designate the therapy. Ligamentous injury is very difficult to identify, that requires first application of the hollow base, and if it is not responding, then we go for the surgery. Now, coming to the subaxial spine, that is from C2 to C7. It is one of the most common injuries that we come across. And the treatment modality, there are the mechanism. It can be done by compressive, vertical compression, restrictive, compressive, restrictive extension, lateral flexion. There are different mechanisms for causing the lesion. And mainly it is classified into compressive injury, tensile band injury, translational injury, and dislocation of the fascias. It can be unilateral, it can be bilateral. Now, when to use the methylprednisolone? It is one of the important questions that come across. Any patient within 8 hours, that is established practice nowadays, should be given the methylprednisolone. The dose of the methylprednisolone to start with is loading dose, that is 13 mg per kilogram for the first hour, it is followed by 5.4 kilogram per kilogram per hour for 23 to 48 hours as infusion. And it is contraindicated, and a lot of people don't favor this methylprednisolone because because it can cause hypertension, it can cause diabetic ketoacidosis, and it is contraindicated in pregnant patients, and it is also contraindicated in patients with IAPMR syndrome and Neurosurgery syndrome. The management of cervical spine, we do the conservative management in the patient not having incomplete spinal cord injuries, not having neurological deficit, and not having any part that is intruding into the spinal canal. Otherwise, we go further surgery to stabilize the spine. In conservative management, we apply the Philadelphia cervical collar that we commonly apply in our practices, and that fairly bit helps the stabilization of this cervical spine. Now coming to the cervicothoracic injuries, it is a whiplash type of injury at that level in which there are no fair bit of changes, there is no vertebral changes, but patient is having lots of neurological deficits. Earlier in the table I had shown that to make a score in coming to the cervicolumbar injury, it is the mechanism of injury. Either it is done by the compression, it is by rotation, translation, or posterior fragment, posterior ligamentous complex disruption. It is very difficult to assess on the MRI. It can be intact, it can be suspicious, or we can assess it as injured on the MRI. Neurological status we can assess in the patient as a radiculopathy, complete spinal cord injury, and IAPMR syndrome. Anything score greater than 4 requires surgery. Less than 4 is managed conservatively. Generally, what we observe in the patient, you can see it here. It is one of the examples of the patient where L1 fracture is there, and in this case, it is a burst fracture that is causing compression of the spinal cord. Any resident can comment about this, what I could have done. Anyway, it is already written that it is a 360 process, fixation of the spinal cord, in which first posterior anterior stabilization was done, vertebral body was taken out, and cage was put there, and it was followed by posterior fixation in the pedicles and rods. So we can get the picture like this. The implant basically that is commonly used in the pedicle screws. There are a lot of different types of pedicle screws. There are from the Indian belt, there are from foreign belts. This is one of the simplest procedures that can be performed. But there are other modifications to stabilize. They are put across the across junctional bars, and there are other things also. It can be done with the open surgical procedure. It can be done with the minimal excessive procedure also. We do both the procedures here at our institutes. So just to give an idea that what is being done in these circumstances, which is the axis and the posterior axis. This is the X-ray for the residents. If any resident can comment about what is the presenting scenario, because this is I have put this image with intent because lots of blunder created here. And I think if any residents can reply this, identify the reason, Dr. Chandra will frustrate him with whatever the bills. Because what I want to emphasize, you can see it here, the facet joint is parallel. And what? The facet joint is jumped here. This is a locked facet. And it can be unilateral, it can be bilateral. What it does, you can see it here, this is the neural foramen. If it jumps, what it will do? If we apply the traction, it will cause the damage to the nerve root and it will cause damage to the spinal cord. So, if without identifying this type of locked facets, if we apply the traction, instead of giving the benefit to the patient, what we will do? We will do gross injustice to the patient, and patient will never going to improve. These are one of the basic things that we should know before applying the traction, before we apply, because in the peripheral practice, a lot of things patients are put on traction for relocation and doing other things. But if you are trained from here, you should take precautions like this so that patient should not deteriorate and he is a real beneficiary of all this. So this is the locked facet. Never put traction. This is scenario. Now, complication of the spinal surgery. I think I had conveyed the meaning that was expected from me. And no surgery is without complication. So, dural tear, CSF leak, infection, lung problems, persistent pain, thrombophlebitis, implant manipulation, breakage, nerve damage, non-immune, surgical side infection, and wound reactions. We re-explode and we are very much dependent upon you. Thanks, we are having so much support from our PMR team, Dr. Pandey, and all those things. Our results are marvelous, and we are doing things very nicely. And the goal of all this is to decompress spinal canal neural ailments, provide stability in neural facility, early mobilization, prevent displacement and deformity. The take-home message is early identification of type of spinal injury, ascertain the extent of spinal cord injury is complete or incomplete, judicious use of cervical immobilization devices as cervical collar, allowist, orthosis and braces, never put traction in locked facet injury, patient with neurological deficit and cord compression needs stabilization by surgery, rest can be managed by conservative and by immobilization, and judicious use of injectable methylprednisolone is important. Thanks organizing for giving the opportunity.
Thank you so much, sir. So, Professor, this examination, what are the indication to go for conservative, what are the contraindication for conservative or indication for operative, what are the complications we are looking for. And as we all know, and we all support, and all we in the same page that we don't support distraction, unnecessary distraction at all, because you will not support of that. So many question and answer has already been answered, in fact, by this talk. Yeah, Amber, you want to say something? Just be brief, be specific.
Person can be mobilized from the next one. He is doing, and then we used to delete from the next one. As a lay person. Spinal mobilization. Yeah, now it is a lot of kids are there. Earlier it was, fixed with the vertebral body and but I expect that you are asking me how much flexion, how much extension that I can carry out. Yes. So definitely it's going to limit the extent of that flexion extension, but mobilization can be there to perform the future.
There is a memento from AIIMS Patna to my fellow colleague. And Saul, customary Saul, to honor and keep asking these things in a right, we also giving it back.
Thanks a lot to the organizing team. And